In our genetic section, the next topic is muscular dystrophies. So, in the muscular dystrophy, the first most common muscular dystrophy is Duchenne muscular dystrophy. Duchenne is actually a dystrophin gene mutation. In the Duchenne muscular dystrophy, there is a mutation in the dystrophin gene, and this dystrophin gene, actually physiologically what happened, the dystrophin gene, it encodes a protein known as dystrophin protein, and this protein, it actually help to anchor intracellular cytoskeletal protein known as the actin. It binds intracellular cytoskeleton actin protein, anchor it, and binds to the transmembranal protein, which is alpha beta dystroglycan, which further bind to extracellular environment. So it is dystrophin is actually this anchoring protein. It anchor actin to the transmembranal protein and hence help to stabilize muscular fiber in the skeletal and cardiac muscle. So now this dystrophin gene is present on the X chromosome. So it's a X-linked recessive. Recessive mean it affect the boys. So X-linked recessive case skip generations affecting the boys, and in the we have two categories: Duchenne muscular dystrophy or Becker's muscular dystrophy. So Becker is a pretty much mild type of case. Duchenne is a very severe case. Becker's is affecting the patients which have the age of greater than 5 years, like early like 5 to 10 or 5 to 15 years of age. And Duchenne muscular dystrophy, it particularly involve 2 to 5 year age of male child. In the Duchenne muscular dystrophy, we have the frame shift mutation or nonsense mutation. Frame shift means non-divisible of 3, and in the Becker's we have the non-frame shift mutation or divisible of the 3. What does this frame shift and non-frame shift mean? We will discuss it later on in the genetics section. So it's a nonsense mutation, and it can result in a truncated or absent protein, absent dystrophin. And in the Becker's we have a non-truncated partially functional dystrophin protein. So this is the pathophysiology, this is the physiology, this is the pathology. So actually what happens in the messenger RNA, we have coding of serine, UCA, serine protein coding, and it prematurely stop by code UGA or any UA or other stop codons. So actually there is a mutation over here, and it results in a nonsense mutation, and it results in a frame shift or non-frame shift mutation. So what are the consequences of this dystrophin gene mutation. First one is there is a starting from the pelvis, ascending weakness or paralysis, and then we have waddling gait. Also we have a Gower sign, which is pretty much classic sign in Duchenne muscular dystrophy, and also in the other dystrophies like polymyositis. So these three are very much important points in we have also a calf pseudo hypertrophy, and the most common cause of death is by the person is in the Duchenne one, the person is wheelchair bound at the age of 12, and most common cause of death is dilated cardiac myopathy. So when this frame shift mutation happen, it actually causes the progressive muscle damage or necrosis, leading to increased creatine kinase and aldolase. Or genetic testing, we can diagnose it by genetic testing. And progressively the damage of the muscle, it can lead to fibro fatty replacement of specifically the calf muscle, leading to pseudo hypertrophy. So this is all about the first most common cause of muscular dystrophy. The next one is the second most common cause is myotonic muscular dystrophy. It is autosomal dominant and affect every generation, structural gene defect, and it is anticipated. What is anticipation? That it affect adults. Early onset and increase in severity is known as anticipation, and it affects 20 to 30 years of adults. And it is actually a CTG, a repeat expansion in the Dystrophia myotonica protein kinase gene, which leads to abnormal expression of this myotonic protein kinase, and it results in the difficulty in the release of contraction, myosin and actin contraction. Actually the contraction happens like this way. So in order to relax this muscle, we have to separate them, and this separation happen because of this protein kinase. So now this protein kinase is abnormally present, so there is the contraction happens, so now it cannot be reversed. So there is a difficulty release of the doorknobs. This is a presenting brain, or difficulty in release of the handshake. The muscle in a state of constant contraction, so there is a muscular wasting. In the heart muscle there is arrhythmia. Also we can say that it can lead, almost all patients are suffering from cataract, which is my possible theory for this cataract is in the cataract we have a particular channels which are muscular boundary ciliary body, particular channel in which we have circulation of vitreous humor and aqueous humor circulation. So whenever those little muscles are affected, there is a constant contraction of that ciliary body, so no flow from aqueous humor to into the into the no, there is the channel is pretty much uh, interfered, so there is a accumulation of aqueous humor in the eye. So this is the my proposed mechanism for producing cataract. Then also we have a atopy, which is a frontal balding prematurely in men. Also there is a gonadal atrophy. This alopecia is because of the contraction of the scalp muscles, and which can lead to the which decreases the opening of the pores of the scalp, and which can causes the which restrict the growth of the hair. Like gonadal atrophy, when when gonads are physiologically gonad develop from abdomen to the extra from abdomen into the pelvis. So when this muscular sheets are constrict that abdominal descent of that gonad, then the gonads present remain persisted in the abdomen, which lead to gonadal atrophy. So this is my proposed mechanism of how the cataract happen, how this frontal balding, and how gonadal atrophy. So this is all about the muscular myotonic muscular dystrophy.